I'm happy to host this meeting on behalf of the UK Symptom Chemical Network. And this is the first of an experimental session in terms of an online meeting. And we're pleased to welcome today Carl Philpott. He's been trained in sinus and skull-based surgery at St. Paul's Science Centre in Vancouver. And he's a senior lecturer in the Norwich Medical School. And he actually established the UK's first smell and taste clinic at the Paget University Hospital. So I'm very pleased today that he's agreed to give us a talk on coronavirus and anosmia.
Well, thanks very much, Krishna, and good afternoon to everyone. I hope this will be an informative talk. I wrote the talk on Monday evening to give a preliminary version to our trainees locally. And I realised last night that this situation is so rapidly evolving that many of the slides got changed just for the volume of information that's coming over the course of a couple of days. So it's rapidly evolving all the time. And I'll be very interested to see what people's own thoughts, anecdotes and experiences are and where we go next. Right, let's get these slides to work. So what we'll do is talk about how common these symptoms appear to be, where we are in terms of lifting it as an official symptom, the differences between what we're seeing with coronavirus pathology and the classical post-viral olfactory loss, some thoughts around the pathophysiology, some of the issues around healthcare workers' exposure, and a little nod to treatment advice. So I think one of the, a number of factors sort of come to light when we start delving into this subject, because largely what we've been relying on so far is reporting. And because we're trying to keep our social distance from people and not wanting to spread infection, obviously getting up close to people and testing people and looking in people's noses, obviously hard to do as part of the equation. One of the things that I'm sure as an audience you're probably all aware of is the reporting between smell and taste and what people really mean by that when they talk about it. So confusion over the understanding of the process of retronasal olfaction, and therefore if you're relying on surveys, getting that information sort of weeded out. The other problem you've got, of course, is about who has been tested, and we know certainly in the UK the levels of testing have been far below what the government were wanting and predicting compared to other countries, and that sort of shows through in some of the studies because the percentages of those being tested and percentage of those reporting symptoms are different things. It's marrying those two up. The other issue, of course, if they are tested, is that the sensitivity of the PCR-based test at the moment is around 70%. So even if people are told they're negative, it doesn't necessarily bear true, perhaps in 30% of cases. I think the other thing that's important to consider is that a lot of the reporting is probably coming from the relatively well people. And of course, the severely affected people may very quickly deteriorate and end up hospitalised and not be in a state or capacity to report on symptoms that are not really of a concern to them when they're perhaps heading towards a ventilator or on a ventilator. And of course, if they don't recover from that, we never get to find out about those symptoms. So there is perhaps a reporting bias there towards the more mildly affected people. So to take us back sort of through the story so far, of course, this is where it began, the Wuhan province in China. We've now sort of racked up over 3.3 million cases globally and over 230,000 deaths so far. Initially, the reports going out of China were really based around the sort of non-specific symptoms around the viral illness. And then, of course, we got this first report from just over 200 hospitalised patients from Mao et al. And they reported 12 with reduced taste and 11 with reduced smell. So if you add those two together and as chemosensory dysfunction, you're talking around just over 10% of their sample. And of course, those were hospitalised patients. The next big sort of reports to come in was from Iran, and this was a much bigger study, so we're looking at 10,000 odd participants here. And then we're seeing much higher rates of reporting of smell loss, so nearly 50% of reportees in the study. And the sudden onset of the nature of the loss was reported in 75% of those responding. And then, of course, we get to Italy, which has been one of the big centres of the outbreak in Europe. Again, this is going to a much smaller study, but it was hospitalised patients again. They're only able to interview 59 of those patients, but at least a third were reporting one or the other of smell or taste disturbance, and about 18% reporting both. And then 1 in 5 reporting symptoms before the admission, 13% during the stay, but interestingly, taste alterations being more frequently reported before hospitalisation. And then we sort of zoom out a bit to the a wider European picture, and this was a study reported by Lecce et al. With 417 mild to moderate COVID positive patients. And you can see the percentages going up higher again, so we're now in the high 80s of patients with reported olfactory and gustatory dysfunctions. And they reported 12% as having these as the first symptom. And of course, then we get to the UK. So the big reports from the UK was the report from King's College London using their COVID app tracker. So they had 1.5 million individuals reporting symptoms via this app, but only 1,702 reported having had a test. And therefore, if you look at those that had a test, it's a much smaller percentage, and this is one of the issues I was bringing up earlier. So you can see that there were just short of 600 that were positive, with the remaining negative in that sample. But of those that were positive, you can see that there were high levels of smell and taste dysfunction, so nearly 60% of cases. There was also a separate study, which was a survey by Hopkins et al. And again, only small numbers there have been tested, only 80 have been tested for COVID-19. You can see there that a large proportion of patients under the age of 40, and 73% have been reported as female. And of course, it's discovered America too. Not that this would have us believe it was the right kind of thing to worry about. But the American ENT Society published this study, which was sort of an early report of their clinician reporting tool, and they reported on 237 entries. Again, you can see that 73% of subjects noting anosmia, initial symptom in just over a quarter of them. Some improvement was noted during the course of that initial reporting in 27%, and the mean time to improvement was around about a week. And they found that within 10 days, 85% had improved. So an apparent short duration of effect. So if you kind of summarize some of these cases, or these studies rather, together, and add up some of the numbers, so you can see that if you look at the proportion of olfactory dysfunction in positive cases, so looking at COVID positive cases, then we're talking about 61% prevalence. And then if you spin that around the other way and think about it as if you've got COVID, if you've got olfactory dysfunction present, how many patients are COVID positive? It's also conveniently 61%. Now, I'm sure these numbers will change again as more and more data pours in. This was also a systematic review and meta-analysis that was published just earlier this week. They looked at 10 of the studies so far, and they reported the prevalence in their review as 53%, gustatory dysfunction being 44%, and using a valid instrument assessment. And of course, this is a report via a survey rather than any formal psychophysical test. They were finding an 86% prevalence of olfactory dysfunction. So a little bit more about the timing. So this is a report from some Italian data. So you can see here those reporting it as the only symptom around about the 3% mark. Prior to other symptoms, 12%. Alongside other symptoms, about just short of a quarter. And then after other symptoms, again, just over another quarter of the sample. So we've been surveying healthcare workers in the two main Norfolk hospitals, the James Paget and the Norfolk and Norwich. And so this is a sample of 142 cases so far that reported on. And you can see that, again, similar numbers reporting it before other symptoms, 63% reporting it after other symptoms, and then nearly 20% here reporting it as the only symptom. And I guess this is of relevance when we talk about healthcare workers. The other thing that was interesting to look at is other symptoms, because again, if you go back to initial Chinese data, very small percentages looked at as also reported in terms of other nasal symptoms particularly, and yet here we're seeing higher reporting around nasal blockage, runny nose, and then we've got symptoms carrying around nasal irritation and burning, and distortions. This is again sort of come out this week. So this is scaling up tenfold, another European-wide study by the same author as the other one. And this is now 1,420 patients. Again, large percentage female. We see this lower mean age. Mean duration of symptoms being around 11 days. And again, we look at the other symptoms being reported. We're seeing nasal obstruction high up here. Similar to loss of smell. Cough obviously is one of the official symptoms. Fever, one of the official symptoms, actually lower down the chart here. So we've got things like fatigue, and sort of fatigue came up as a high number in our local healthcare worker data. And then I just saw this flash up by the GCCR Slack group earlier this morning. This was a link to this Twitter monitor that the Penn US group are sort of running on a website, and there's the link for it here, and you can see reported symptoms here. So breathing difficulties, fever, general ache and fatigue. You can see smell and taste loss as being the next most common thing to be reported via Twitter. So I thought what I'd do is just sort of zoom back a little bit and think about when we talk about post-viral or post-infectious olfactory loss or dysfunction generally, and where that fits in. Generally speaking, looking back over previous studies, we think that post-viral loss represents probably only actually about 10–11% of all olfactory loss we see in the community at large. But we see a disproportionate amount for those of us that are involved in dealing with it clinically, and I'll come back to that in a moment. The typical post-viral olfactory loss is something that typically appears as part of a viral illness. The other symptoms are present as well. And then as the other symptoms abate, suddenly the patients realise that the one thing that hasn't disappeared is the olfactory dysfunction. And they often recall that infection as more severe. And not infrequently they talk about preceding episodes where they've had a temporary loss of smell, but that's come back afterwards. So may suggest, oh, sorry, I've gone back there. May suggest perhaps a cumulative effect of damage on the olfactory epithelium. And of course, in some cases, it's important that we ensure that any crossover with chronic rhinosinusitis and localized olfactory cleft disease is considered. So the classical post-viral loss, we do see more women than men. It's a ratio usually about 2 to 1. But it tends to be an older age group of 40 to 70 years. And the reports of spontaneous recovery are usually at least a third of patients over a 3-year period. So bringing back to the sort of percentages, this is just to emphasize that this kind of lower of post-viral and the wider causes of olfactory loss is largely because a large proportion of cause of olfactory loss are based around chronic sinusitis, and because patients have other symptoms as well in that condition, and it is not always necessarily the main focus of their problems. They obviously maybe focus on other things such as nasal obstruction. If you look at this was a study published in 2013, which was in part an online Google survey, but they reflected upon the other sort of studies over time up to that point. And you can see the kind of spread of data, but you can see sinonasal disease as the sort of the top headline for olfactory loss, but post-viral cases coming in as the sort of next most common. And you can see the spread of data sort of here, but obviously this particular study that I just showed you was trying to sort of capture the bigger picture in the general community. Of course, for those of us that do a specialist clinic, we do see that this is one of the most common things that pops in, although when I last did this, which was about 5 years ago, actually the idiopathic cases were slightly more numerous. If we ask a sort of focus group of people who are sort of asking to stand up and be counted for their olfactory disorder, then actually the post-viral cases are the most numerous, as we see in the membership of our charity Fifth Sense. So how does a typical viral olfactory loss wreak its havoc? Well, reported viruses to cause this have been a number of agents, but the coronavirus family has been reported as a causative agent previously, so I guess it's not surprising we're seeing problems with it now. The typical sort of pattern of damage is the sort of the viral hijacking of cell apparatus, so classically in a rhinovirus case, causing a recruitment of the appropriate white cells, an inflammatory cascade, and then the typical, in a healthy patient, elimination of the viral pathogen via the T lymphocytes. And in the process of that happening, we see a loss of olfactory receptors in the epithelium. And if you zoom in on the finer detail of what's happening to the microscopic level, then typically what we're seeing is a sort of loss of olfactory sensory neurons or a loss of the ciliated surface, and therefore reducing the available area for odor molecule detection. So to summarize so far to this point, what we're seeing clinically is this kind of key difference that the COVID type of viral smell loss or dysfunction is really skewed towards females and is hitting a younger age group than we normally expect. But I mean, yesterday I did a telephone clinic for lots of the smell and taste patients, and the post-viral ones, and these are all real pre-COVID referrals, very much describing this slightly more of a typical, it was there as part of all the package of viral symptoms that they had at the time, and it was only really as the other ones abated, they noticed it sort of, being, oh, I still can't smell or taste, it's still there. Whereas a key example, my anaesthetic colleague who's been tested COVID positive and had smell loss, he said, well, 1 minute he was sipping his coffee, he could smell his coffee, next minute, bang, it was gone. And it seems to be the sudden nature that is one of the key things that we're seeing come through in the reports. So how is the COVID-19 virus wreaking its havoc on the chemosensory apparatus? Well, it's clearly a crafty virus, and it may be working in perhaps a number of ways. So there's one suggestion that it's potentially got neuroinvasive potential, and this work is based on some of the previous coronavirus research, particularly in mice models, suggesting that actually it may be invading central structures, and that may be why that some of the more severe cases are not just doing badly because of respiratory tract inflammation, but actually perhaps because the virus is involving the respiratory centers in the brain. And I guess if it's doing that, it's not impossible to believe it's taking up shop in the relevant parts of the olfactory apparatus. This was a recent publication again, which was sort of released before peer review, but available online, which suggested that the virus actually is potentially through these receptors, those two receptors and the protease TMPRSS2, attacking the supporting cells of the olfactory epithelium and causing an architectural disturbance, and perhaps maybe an explanation for why we're seeing such short-lived cases. There's also evidence such as this one here, which was a case report in the JAMA Otolaryngology journal, suggesting that there may be a sort of short-term inflammatory effect in the olfactory clefts. And certainly we can see evidence of this from another case that I saw locally. And so, if you look at individual case reports, again, you can see sort of, and these were sort of all actually doctors, and interestingly, all male doctors who sort of, report various patterns of, when the smell loss came in. And so far have seemed to have been all relatively self-limited. I just thought I'd put this one in there just to come back to the issue and perhaps an opportunity for debate around what we're seeing about the reports of smell and taste, because a lot of it's being reported rather than tested. One of the key things we know that if you actually look at the discerning difference between what patients tell you around smell and taste loss and how that actually compares when you test them, is that the difficulties with language and also people's perception of experiencing smell and taste together and be able to separate those two is often difficult when you put into practice testing. You see that most of the time true gustatory loss is actually quite a rare event. And yesterday in my clinic, I was seeing that very much all the time. The patients say, well, I want to talk to you about my taste, and you can go, okay, well, if I put sugar in your cup of tea, would you notice the difference? Actually, yes, I would. Okay, so that's a very difficult thing to kind of to weed out on a larger scale. So should it be listed as an official symptom? Well, certainly the Americans were first in doing this, and I now see that a number of other countries are following suit. So hopefully we won't be too far behind in this country joining the throng. As I alluded to already, is there a potential risk to health workers or to non-infected patients through healthcare workers? And so again, this is coming back to our survey of our local healthcare workers in the 2 Norfolk hospitals, and this is asking them to report again 4 weeks on from the onset of their problem. And actually I was interested to know if they'd sort of self-isolated or carried on working as normal. You can see actually large proportions carried on working because they were told often that smell loss wasn't an official symptom of COVID-19. And I also asked them how they got better, and you can see that we got this kind of 13% figure saying actually no, it hasn't yet, and that seems to be kind of roughly what's emerging out of the larger sort of data in the field at the moment. What's also interesting is the other sort of qualitative disturbances that are coming up. So not surprising, I guess, for post-viral olfactory loss, but proportions of parosmia, phantosmia, and also chemesthesis, so this kind of burning and tingling sensations in the nose and or in the mouth. So as a lot of you are probably aware, there's kind of work ongoing, and the Global Consortium for Chemosensory Research has sort of already got a large volume of data about over 4,000 cases coming in, and that's hopefully going to be sort of being published soon. And there's also, I've just learned this morning from Barry Smith, going to be, we've had approval for Essex for an adjunctive version for the UK, which will also be released as a survey very soon. So we look forward to seeing what that data shows. So just a quick final nod to treatment options. I won't be recommending ultraviolet light or disinfectant injections as Mr. Trump did. Typically for our post-viral cases, this is the sort of way I would tend to sort of talk about sort of managing these cases. And of course, I guess the difference is that normally I'm faced with seeing these type of patients often several months down the line from the moment of the onset of the problem, once they got through all the referrals, so the barriers of getting referred in the first place. Smell training, I guess, is one of the core sort of components of this, and we'll come back to that. Now, the guidance as it stands that we've put out through the British Rhinological Society and UK has been an avoidance of steroids, in part because there was this kind of report from the previous SARS epidemic that suggested that giving oral corticosteroids could result in a higher viral replication. Now, actually, as it stands, there is one of the existing COVID-19 trials underway which actually is one of its arms, has got systemic steroids being given to patients. And I did actually check with our R&D lead this morning to sort of see whether he was aware of any suggestion that that arm might get pulled, because there was talk that they might pull an arm if there was any concern that it wasn't showing to be either effective or potentially doing worse than the control arm. And as far as you can tell, that's still ongoing. So it may be this advice gets revised. I guess against that, obviously, if you've got patients who are getting better within a 2-week period, then you'd only be thinking about this for people after that initial sort of time frame that have persistent symptoms. We also were cautious about advice regarding intranasal steroids, again, because of concern around causing nasal irritation and increase in viral shedding. But obviously for patients already using them for other underlying inflammatory disorders such as chronic rhinosinusitis, then those patients should probably continue with them. So I'm sure you're familiar with smell training, and of course this was work that Thomas Hummel and other colleagues sort of put out some fantastic data for, and has shown to be a nice beneficial thing that patients can do in their own time. And of course that then got sort of updated with the modified olfactory training, which showed that if you change the odours every 3 months, actually you can increase the potential benefit of that safe intervention. And of course the position paper on olfactory dysfunction highlighted all of the studies at the time that was published in 2017 that had looked at this to date. So I think there's now sort of good evidence that's a kind of nice simple thing, and a number of websites that support that process. So in summary, I think we can certainly see that there's an undeniable link between coronavirus infection and these chemosensory disturbances. We're certainly seeing that it seems to be affecting a younger and more female demographic. We're also seeing that qualitative disturbances appear to be common. If you are working with anyone who can't smell, then I think we should definitely be getting them to self-isolate based on this evidence. I think there's clearly debate around whether this is a local or a central effect, or maybe that it actually varies from case to case and affects people in different ways, and maybe in combination. Clearly the evidence so far is that it's self-limiting in the majority, but I guess time will tell as to what the burden of post-viral olfactory loss will be in the wake of the pandemic. And I guess if nothing else, we can certainly point people to undertaking smell training as a safe option if they have an ongoing problem.